Good morning, everybody. My name is Abraham, and I work in the senior living industry. So I started as a social worker back in 2003, working in a nursing home in Chicago, Illinois. And all I did was discharge planning, and then I did admissions and finance and business office and all that stuff back in Chicago. And I used to work with the hospitals a lot because I always took patients in and as admissions, and then I just
You're muted.
No, he's frozen.
Abe, it looks like you ended up on mute. Somehow you ended up on mute.
sorry, I did not touch it. Am I back?
You're back. Thanks.
Okay. Sorry about this. Blame it on Zoom, please. So I became an executive director in a continued care retirement community where you have independent living, assisted living, dementia care, and skilled nursing. And I was precepting administrators, and I have an administrator now that works with me. And I got promoted. It's called Buckner Retirement Services in Texas. We are called Buckner International. We do children and family services across 7 other countries and in Texas, and we also have senior living communities. That's 6 of them in Texas. So I was made the senior executive director last year to assist with our strategic growth. I know Jay Hobbs is here from Senior Living Properties. He works in a similar industry. Thank you for your service. In 2018, Governor Greg Abbott appointed me to be the chair for all licensed nursing home administrators board, and I still serve there, and my term ends in 2027. Moving on, here's my disclosure. I work in a senior living community right there. You can read it. Since the time is so short, I'm going to just skip, if that's okay. Go to the next slide. Learning objectives, understanding the post-acute care services available, discuss transitions of care between hospital and facilities, discuss care coordination, discharge planning, understand the challenges during and post-transition to nursing homes, recognize and respond to client needs in post-acute care and other long-term care residential facilities. While we go to the next slide, I will tell you this. I actually built a course for another college in this specific topic, so it helped me to put things together. Some of the transition and issues that we get to go through or we see on the nursing home side is when, if you really think about it, when an individual goes to a hospital due to an unexpected illness, it affects the individual's emotional, physical, psychological, behavioral, social, and spiritual well-being. That's what we end up in the nursing home side. How can we take care of them now? Now, not only they went with the hip fracture to the hospital, but they come out with all these other things, the family members, all these people that we had to worry about in the long-term care industry, the post-acute care. The challenge of finding out they cannot go home is devastating. Imagine somebody goes to the hospital and then somebody walks to your room and say, you know what, you can go home. You need to go find a nursing facility. There's always that nursing facility trauma itself hearing, because it is always nursing home, that those 2 words are dangerous words, I guess. It's always taken in a different concept. Oh, I had to go to a nursing home. That's how people think, and it is not easy. And that transition is not going to be easy. When they hear they need to go for a rehab or they can never make it back home, it's actually a huge deal for an individual. Think about ourselves if we are in that situation. Some of them will end up in a post-acute or long-term care facility for follow-up and treatment. This transition is not easy. And let me tell you, same thing about the family members, the loved ones. Improving communication during transitions from acute care hospital into long-term post-acute care settings is very important for clinical staff to have the information they need to admit and care for the patient with accurate medical information. Handing over. This is so important. When somebody moves from the hospital to a post-acute care facility, I will tell you honestly, the handing over is not the best. It is not the best. The post-acute care facilities are not given the proper medications. Some of the medications they're added, the patient doesn't know. When they come to the nursing home, they find out, what? I have a new medication. Where does this come from? And the family member ends, they get mad at the facility thinking it's the facility who did it. The whole discharge planning from the hospital and the transition, the more you communicate, the more better for this individual coming to a facility. It also helps the facility. It also helps the family members. It helps with speedy recovery. They know the plan of care, where they're heading. Improving that communication is so important. Cross-continuing collaboration. I know Medicare and CMS have done a lot of initiatives the last decade or so. So we will be seeing a lot more better things coming our way. The bundle payment, the networking with hospitals and insurance companies and long-term care together. There's all kind of things that's coming. Hopefully they speed it up because we really need that. We have some hospitals, I'll tell you, in Houston, they come to the facility to follow the patients, which is a good thing. We really want that happen across the country, everywhere, which helps the patient. They do a personalized case management by doing that. We'll go to the next slide. Key elements of ideal discharge planning. By the way, I got this. You see the source at the bottom of this page. I took it from there because it's a really good tool that you can use. It's just a PDF thing. The ideal discharge planning elements, include the patient and family as full partners in the discharge planning process. Sometimes we talk to the patient, but we don't talk to the family. Sometimes we talk to the family, but not the patient. It needs to be together. That is very, very important. And this PDF, this handout right there talks about it so clearly. I only took a little bit from there for the session today. And describe what life at home will be like. Review the medications. Highlight the warning signs and problems. Explain the test results. Make follow-up appointments. Educate the patient and family in plain language. If you speak in your language, they may not understand the terminology, the discharge process, and the next steps throughout the hospital stay. Assess how well doctors and nurses explain the diagnosis, the condition, the next steps, and all that. Listen to and honor the patients and families' goals, preferences, observations, and concerns. Sometimes we don't do that. We tell them this is the only thing you have to do, but we're not knowing. For example, I'll give you a quick example. One of the patients walked into our building and said, I'm worried about your security. I'm worried about the security aspect of moving into your community. We thought they're talking about security in the nights that watches my building. We're like, oh yeah, we have 24/7 security system. We have a camera system. This patient waited and then said, that's not what I asked. I want to know, do you check all your employees' background checks? Are they all good employees? So you really don't know what that patient is thinking. Please, you need to go to that level to listen to them. That way, you know what they really want to hear and what they really want clarification from, because this whole transition is not easy for them. It's a trauma itself. And we'll go to the next slide. So here there is, this is just one page of the PDF. We are afraid to click that link unless the organizers wants to do that. This checklist is from CMS. I highly, highly, highly recommend. I have not found something better or even equal to this discharge planning checklist. This is a great checklist a hospital discharge planner can work with the family and the patient. It is very simple, very basic, and it has all the checklists that you need to do. And half of that can be done by the family and patient themselves. Giving a copy of this to the patient and the family is going to open their eyes. They have some more reading materials. Try to do that not on discharge day, but we're going to get there. But you need to do that way ahead. It starts, I'm not going to give you a quiz question answer now, but it starts earlier. You will get to see that a little later. This PDF checklist is made by CMS. It had a body of people, multiple people that came together. Look at all the resources they used before they put together this checklist. You will love it. It'll be good for the nursing homes to have. It's good for the hospitals to have. It's good for the transitional care people like the doctor, the specialist, the social worker, the nurse case manager. Everybody should have a copy of this list and hand over to the patient and go over the checklist. Maybe not all of them are applicable. We might have a hard time if we click that link. So I might just say we might just pass on to the next slide, but you're more than welcome to look at that. Now, the next 2 pages, I'm going to tell you, these are directly from the nurses that I've worked with the last 20 years, the CNAs, the families, the patients, the doctors, and the NPs. I just put together a few main things that I've always heard as concerns upon transition to post-acute care. Number 1, patients are not educated properly on their plan of care upon discharge. I'm not saying it happens all the time, but this is a trend we do see in this industry. Family members next of kin have less info during the transition. Medication orders are not reviewed upon discharge and make appropriate changes if applicable. Some of them will come here with a medication that should have been stopped before they leave the hospital. Imagine the doctor here is not the same doctor there, and the doctor here does not want to DC any medicines that the hospital put on, and this patient has to be on there for another 7 days unnecessarily. You know what that means. Triplicates and prescriptions not given during discharge. For example, a patient leaves at 7 o'clock in the evening. Imagine they come to a nursing home. We don't have a pharmacy on board. We don't have a doctor that's on site. It has to be the hospital that has to probably, hey, let me give you your night medicines now. So when you get there, it's too late. Let me give you your food now. So you take dinner so you won't have a problem when you get there. Hey, let me send you this triplicate. So when you get there, you give it to the nurse there and they can get that medication from the pharmacy easily, because pharmacy is not going to give those, the medications that you definitely needs a triplicate for, right? So the scheduled medications, some of them are very, very important to their life, their care, like a pain medicine. Tylenol is not going to keep up with them. So they do need some of those medications, and the doctors are not easily to be reachable in the nursing facility sectors. Imagine nursing facilities in the rural areas. Imagine, NP not responding. How can this nurse, the patient, the family in the nursing home can get that most important patient towards a recovery? They have to wait. And imagine it happens Friday evening. Sometimes it's a big mess and a chaos until we get the pharmacy to deliver that medicine, because they don't deliver without the triplicate. You know what I mean? And we do need that transition part done in the hospital level. So importantly, facilities have to work with them. It is not easy at all. All right, we'll move to the next slide. This one also, same thing. Late evening and night discharges. Why are we discharging a senior who's 95 years old to a nursing home after 9 o'clock in the night? Can I tell you something? We get discharges on Fridays. We get discharged at 12 o'clock in the night. Somebody who has not taken a shower, somebody who is so gone through so much of problems in the hospital. Is that the right time to discharge this patient? It takes a lot of effort on the nursing home side to bring that patient, the family, to be happy and comfortable. So these are some of the transitional care concerns I'm sharing with you. I bet it is not eye-opening to some of you might know these. Poor hospitality. Sometimes some hospitals don't have good hospitality. They do complain to us about that, meaning, did you eat some food before you go? Can I send you a go lunch or dinner? Because by the time you get there, probably the transport is 2 hours away or 1 hour away, or you're going after mealtime. What about hygiene? Some patients say we never get a shower. We have never taken a shower. Offer them bed bath if you can in the hospital. That'll help this person. It's a human being. Paperwork transfer to receiving entity is often not consistent. So we get a fax discharge orders, and then 3 hours later, the patient will bring a discharge document that is different. It doesn't match. Now the nurses are worried about, what am I going to follow? Paperwork transfer, next one. Premature discharges lead to rehospitalization. Everybody knows this. There's a lot of studies about this. And we don't want the patients to go back to the hospital. The rehospitalization kills everybody. It kills the hospital reimbursement. It kills our reimbursement. The whole process is bad. Also, the health of the individual is so important. It's not good. Once they go back to hospital, they get more sick again. A disconnect from the hospital is often felt by the patient, their next of kin, and the receiving entity post-discharge. We'll go to the next one. Here is the favorite part. It's called the quiz. There you go.
All right, we're going to end the poll and share the results.
So now we can scroll through the results. It looks like, for example, on the number one, 100% of our participants who responded said true. So we can now go through and scroll through the responses to all the questions.
Yeah.
Sure.
So Dr. Matthew, would you like to respond?
Thank you so much. You know, when you posted that, it didn't show up on my screen. So I'm going to just trust you. So patients who receive a discharge plan upon their hospital discharge must receive a legible, complete list of medications they should take post-discharge. Did everybody say true?
Yeah, 100% said true to that. So as you're going through the answers, we'll let you know how the group responded.
Perfect. The answer is true because Medicare requires that hospitals print a legible, complete medication list that clearly identifies what the patient should take post-discharge. To support patients further, Medicare recommends that hospitals make clear indications where the prescription drugs or dosages have changed from what they were pre-hospital admission. Medicare also recommends that hospitals help patients fill their prescriptions prior to their discharge to ensure that they can start their medication regimen immediately. Second question, Medicare requires that hospitals, requires is the key word, requires that hospitals do the following when implementing a discharge plan for a patient, for an inpatient. Majority said?
We have 30% A, 46% B, 23% D.
Oh my gosh, the correct answer is C.
We failed.
Oh, no. Please educate us.
Yeah.
Equipment suppliers. But by the way, this questions and quiz and answer is also taken from a source. Our organizers know about this. Due to time, I'm just going to move on. Third question, which of the following are assessed by hospital staff completing a discharge planning evaluation?
92%, all of the above.
100% you're right. All of the above is the right answer. The patient's access to insurance, the patient's goals and preferences, and the biopsychosocial needs. Absolutely. Number 4, if a hospital is evaluating a patient to develop a discharge plan, the patient's preferences for care do not have to be considered with developing and implementing the plan. I bet we have 100% answer this one.
I think we might have had some misclicks. We got 85% on false.
And that 85% of them are 100% true. So it is false. Patient preferences and goals for care must be considered. The discharge plan should incorporate the patient's preferences. Caregiver input and concerns must also be considered when evaluating a patient for discharge. Number 5, which entity reviews a patient's initial appeal of a hospital discharge?
We had 46% on CMS and about 20% on QIO, 20% on hospital physician and staff.
So the right answer is QIO. Centers for Medicare and Medicaid Services, CMS, they do not deal with the appeal process at all. And doctors and staff, they cannot. MAC is just a contractor, they don't. The QIO, the Quality Improvement Organization, they have different sections that handles the appeal process. KEPRO is one of them. If you do not know, KEPRO is one of them. All right, number 6, Medicare requires that hospital outpatients who had an emergency room stay or same-day surgery receive a shortened discharge plan.
70% said true.
And I'm going to side with the 30%, which is false. The shortened is the key word there. It's false. Medicare recommends that hospitals consider using an abbreviated discharge plan process for certain types of hospital outpatients, such as patients who had same-day surgery or were discharged from the emergency room. However, it is not required that any hospital outpatient receive a discharge plan if they are outpatient. The only groups required to receive a discharge plan are hospital inpatients at risk for adverse consequences post-discharge. So in this question, emergency room stay is the thing. It's not outpatient. It says that emergency room stay is the key word, and the same day surgery, which is, it's a thing. It's a shortened discharge plan is the key word there. The definition, what CMS says is that Medicare do recommend those things. The only group that required to receive a discharge plan are hospital inpatients, which is 100%, but they do also recommend that you have to do that discharge plan with them. Number 7, when must the discharge plan evaluation process begin for a hospital inpatient? I gave out this answer before.
We had 77% said C.
B as in boy?
No, C, immediately when the patient is considered an inpatient.
Okay, so the answer is B as in boy, because soon as the patient is considered inpatient, you still don't know about the status of the patient. You still don't know what's going on. An early stage of their admission to the hospital is the best time, because you really want to see, you can't start a discharge plan 24 hours before discharge from hospital, which is bad. Immediately when the patient is considered an inpatient, you can't do that right away. When the hospital staff has time to complete the evaluation, that's called laziness. But B as in boy is a reasonable answer over there. But these are not something we are testing you from what I presented. These are just knowledge for you to be aware. I just made that as a quiz instead of a slide. All right. Those are 7. Next slide. All right, here are the key points. Discharge planning starts upon admission. The hospital plays an important role. Poor transition can be traumatic. 360 care is only possible if a patient's transition to the appropriate setting post-discharge is successful. Rehospitalization is a hectic penalty for hospitals. So this is from ccjm.org. I love this. In the past decade, 1 in 5 Medicare patients was rehospitalized within 30 days of discharge from the hospital, and up to 25% were rehospitalized after being discharged to a skilled nursing facility. It's not good. Next slide, please. All right, here are some of the references. I think I am done right there.